I'm a fellow in Medicaid policy at the Center for Community Solutions. Thank you everyone for joining us. Again, my name is Brandy Davis. I'm a fellow in Medicaid policy at the Center for Community Solutions. We are a nonpartisan think tank and located in Northeast Ohio. We also have offices in Columbus, Ohio. So we're glad that you are able to join us here today, just on a discussion of health and justice and what that means. We have here today, we're joined by Dan Mistak, who is the acting president and director for care initiatives for justice in all populations at Community Oriented Correctional Health Services, and is also a senior fellow at the Atlantic Institute. I would also like to give our policy director, Tara Britton, just a moment to introduce herself as well.
Thank you, Brandy. My name is Tara Britton. I'm the Director of Public Policy at Community Solutions based in the Columbus office. And I'm mostly here just to sort of support field questions for all of you who are presenting today, but really looking forward to this webinar and have been talking about this issue of the reentry population and how to make things easier as folks are coming back into society after being in the criminal justice system. So really looking forward to the conversation today. And thank you, Brandy, and to the panel for everything you've done to prepare for today. So I'll turn it back over to Brandy and just let me know if you need anything.
Dan will sort of kick us off here and just a conversation about what the work that he's been doing, looking into legal research and that formal setting. And then we'll go to Patrick Beatty, who is a deputy director at Medicaid, Ohio Department of Medicaid. And he will give us just some level setting about some of the fascinating work that is going on around these waivers.
Great. All right. And I have a bit of some PowerPoint slides too. And I think that you're all going to put those up on the screen. Is that right? Right.
That's correct. Yes.
Perfect. Well, I'll begin by introducing myself again. My name is Dan Mistak. I'm acting president, director of healthcare initiatives for a nonprofit called Community Oriented Correctional Health Services. We started in 2005 with a grant from the Robert Wood Johnson Foundation, which is, of course, like one of the big philanthropies in the health world, in order to try and improve connections between community health systems and correctional health systems, because jails are places where people receive care. And what we want to do is make sure that people are able to have coordinated care, high quality care wherever they receive it. But because of some long-standing policy challenges that we're going to talk about today that are being removed, jails and prisons, but I focused mostly on jails because of the status of people who are incarcerated in jails. People come in and out, and jail healthcare has become a bit of a black box. And so what we're trying to do is to use and leverage the opportunities inside of community health systems to improve access for people while they're incarcerated and really strengthen the health system overall. So what we do is we provide TA at the state, local, federal level in order to just try and improve the systems that operate at the local level and improve policy that's made at the federal and state level. And we do that by bringing together folks who have often never communicated with one another or talked before or even speak the same language, policy language, in order to try and understand that, first of all, people who are in jail are often people with some pretty serious and acute untreated behavioral health conditions, also have some pretty high levels of chronic health conditions. And if we can really start talking about and understanding how health and justice systems can work together, we can really improve the outcomes for people involved in the justice system. The next slide talks about sort of the coaches' a way of thinking about these things. So here we have the person here in the middle. In an ideal system, we would have sort of the health system wrapping around that individual so that they can be able to receive the care wherever they need it, whether it's a physician's office or a clinic or a hospital. And that information can be shared across all those different providers. The care plan can be shared across providers in order to just maintain the momentum for people who are receiving care and don't have any moments where they're derailed. Unfortunately, jails are often excluded from that sort of patient-centered approach to providing care. So what we want to do is build a healthier and stronger system for people who are needing health care, and to really improve the coverage for people so that they don't lose access to healthcare while they're incarcerated, improve population and community health so that people's health doesn't get worse in the jail and then end up impacting people's health in the community, really integrating behavioral and physical health, and of course, lowering costs. There is an underlying secret that is probably too much to go into in all of this, which is a lot of the care, the healthcare costs are borne by a local jurisdiction inside of the jail. And then that really exacerbates the problems of really improving and coordinating care with the broader community system in the community, which is often paid for through a set of federal and state dollars together. So how do we start weaving those together and then driving down the overall costs? And this ultimately is going to support criminal justice system reform. It's going to help reduce recidivism, improve public safety. And one of our biggest goals too at Coaches is to really work to eliminate the racial disparities that exist both in our health system and our justice systems, because those really mirror one another. So I want to get into a little bit just to try and paint the picture of here in Ohio, something that is absolutely true, which is that health, social service, and justice systems are deeply intertwined. So I just pulled these three articles from three headlines from articles that have come out in the last few weeks that we publish a weekly update around health and justice issues at Coaches. If you're interested, you can go to our website and sign up, and we can send that after the conversation here. But one just talks about Cuyahoga County Jail, and that often when people are leaving, there isn't really a lot of there's people have a hard time finding the aid that they need to re-enter. And this is a priority now of Cuyahoga County Sheriff, saying that they want to improve that. And then Ohio is focusing right now on juvenile justice and reentry support in order to try and ease the transition as people are leaving corrections or juvenile justice systems into the community. And that is a case management. I mean, that's really a case management function. And then just wanted to point out this really important and really surprising article that came out in the Cincinnati Enquirer talking about a special investigation that demonstrated in the last 4 years, 220 people have died in Ohio's jails, which is a really shocking number. And so in the past 4 years, at least 219 people have died. That's one person a week. And we're talking about jails, I just want to remind you that for the most part, these are people who have never been to court. Or if they've been to court, they haven't actually had their full disposition of their trial. So no one's been sentenced to anything. They're just being held there because they haven't met bail. And so this is a really shocking outcome for people who are in a facility when they really haven't yet been judged by the system to be guilty yet. So in the next slide, we're going to talk a little bit more about, the folks who are incarcerated. And I got into this work just as a little personal background. I grew up in Trumbull County. And so dad was a steel worker. Mom worked at Burger King. I had the joy of working at Burger King for 3 years too. But I had an aunt who had schizophrenia and was bipolar. And so the first responders, whenever she'd be in the midst of a crisis, would be the local county sheriff. It did not seem strange to me because everyone knew the county sheriff. We all were, friends with them. We knew our deputies. And it wasn't until I got older and became an adult and said, wait, this is not the right way to build a railroad if we're trying to really support people who have some acute mental health needs. And so it wasn't until later I started understanding more and more about the people who actually are incarcerated inside of our jails are people who tend to be low income, people who tend to have pretty serious mental health conditions. And that is and the care that's provided there is disconnected from broader health systems for the most part. So I just wanted to highlight and talk about the fact that these are our neighbors who are incarcerated. These are our friends. These are our cousins. We all know people who have been hit hard by the opioid epidemic and are still being hit hard by the opioid epidemic. So I think that we can't forget that these are our friends, our neighbors, our cousins, our aunts, our uncles. But at the same time, is an interesting profile of people who are incarcerated, and that this slide shows they tend to be people who are low income. And those disparities in income also increase when we start adding in racial characteristics as well. So being Black and poor also could lead to people who are incarcerated tend to be Blacker and poorer than people who are in the community. So really, I think gives us opportunity to pause and think about how these systems are operating on people in our communities. The next slide talks more about the incarceration rate, the racial disparities that exist inside of our justice systems too. So we would be absolutely remiss to not talk about the increased populations of Black and brown populations, American Indian, Alaskan Native. I've done a lot of work in Hawaii. Hawaiian populations are vastly over incarcerated as well. So people who are incarcerated are disproportionately Black and brown. And I think that that's also a really important thing to think about. And then also the people who the workers inside the facilities too are often disparately impacted too, that often they are Black and brown populations who are also working inside of these facilities too, which I think is also a really interesting policy or social question for us to wrestle with too. But outside this conversation today, the next slide talks about, and we're going to go through these a little bit quickly because I want to get to the meat of why all of this is so interesting. But this slide talks about the rates of chronic and infectious diseases inside of jails and prisons, and that's on the left. And we can see much higher, really high incidences of both chronic conditions and infectious diseases inside of jails and prisons, underlining emphasizing the fact that people who are incarcerated have really high rates of health needs. And again, we are forcing local governments to deal with those health needs, often without support from the broader health system. And then when we really compare infectious disease and chronic diseases inside of correctional facilities to those in the community, we see much higher rates than those in the community at large. So this opens up a real opportunity, in my mind, for using jails and prisons for case finding, to identify people who might need treatment, who haven't received treatment in the community, in order to extend and offer care for them too, particularly if we're trying to eliminate things like hepatitis and HIV/AIDS. With the higher rates of incidence there, it's a great opportunity to try and get people into programs to manage those diseases, and then also to connect that management into the community so that there isn't a challenge when someone is trying to come back out. These slides are going to be shared with you afterwards. I just want to say really quickly something about data. Data inside the correctional system, particularly if we're talking about health, is very, very challenging to find. This data here came from 2011-2012 study that was looking backwards further than that. And we just have a really challenging time collecting data that's up to the minute. And often that is because jails are run at a local level, prisons are run at a state level, and the health systems inside of them just aren't collecting that kind of data and then sharing it because there aren't people who are necessarily interested in that. So I just thought it would be really important to point out too that getting a handle on this challenge is also still very hard, and improving data improving access to healthcare, community health systems, and the data collection systems there is a really great opportunity to improve our data as well. The next slide talks about mental health, and for people who are incarcerated. People who are incarcerated have much higher rates of serious psychological distress, histories of mental health conditions. People will say that they have no indication of mental health conditions, but I wouldn't be, and this is a self-attestation in this study. This is not necessarily a diagnosis. So I think it's really interesting to see the data here, and then also to be a little bit suspect of the data at the same time, because we understand that people who are self-attesting inside of facilities too tend to underreport mental health conditions. And a reason for that, at least in New York City, where there was a study, is because that there's a concern that if someone self-attests to a mental health condition, it might put them into a setting inside of the jail or prison where they don't want to be, and might end up staying incarcerated for longer, rather than being able to move through more quickly. The next slide is talking about how on both ends, coming into the jail and coming out of the jail is a major health event. When people are arrested and taken to jail, there's an Adam 2 study that showed that fewer than 1 in 10 people who were arrested actually and test positive for substance use in the community have received any treatment in the community in the prior year. So that's a major population that is not necessarily being reached by the substance abuse treatment programs that we have. And then when they enter into the facility, they're offered care in there that might be disconnected from the broader community. And then when people are released, it's also a major health event. We would never discharge somebody from a hospital without like a discharge and connection to community services. And then but we do that every single day with jails, where the average length of stay inside of a jail is less than a month. So people come into the jail, they're getting treated, and then when they're released, they're facing 12 times more likely to die of all-cause mortality. And when you start bringing in overdose statistics from both Washington and Massachusetts, we're finding 120 times more likely to die of an overdose post-release. 80% of those people, I should also add, who are entering into a correctional facility with a chronic condition have not received treatment in the community prior to arrest. So jails are places where people are in pretty critical need of both behavioral health and physical health treatment. They have not necessarily received it in the community. And then we're trying to sort all of that out inside of a jail for the safety of the person who's incarcerated, but also for the correctional staff who are working there as well. And then those individuals are released with much, much higher rates of death and overdose. And so there's a real need to try and improve connections both before people are coming in and also as they're being released from incarceration. So how did we come to this system? The next slide will start talking about a little bit of that. This is where we kind of are right now. So before the Affordable Care Act and the actual expansion of Medicaid, most people just didn't have access to healthcare in the community. So this sort of conversation would have never happened in the pre-2014 world. But since 2014, Ohio was one of the first states to expand Medicaid. And that has really opened up the opportunities to start on the front end, improving access to care for people when they're in the community, improving access to substance use disorder treatment, improving access to the medications for opioid use disorder. But we have a major challenge, which is that, again, inside of the jail, those community systems have a real challenge reaching in because of some long-standing statutory barriers. So how do we move towards this next opportunity? And what is the barrier to actually creating this continuous coverage for people both inside and outside of the jails and improving financing, improving the provider pool? And that is something called the inmate exclusion, which we talk about on the next slide. So the inmate exclusion policy was actually written into the Social Security Act back in 1965. And what it says essentially is that you can be totally eligible for Medicaid, meet every single criteria for Medicaid eligibility, but the moment you're booked into a jail, you lose access to those Medicaid services. You just can't have them anymore. And then when you're released, you have to then re-enroll, depending on how the state operates. Some people have their Medicaid terminated while they're incarcerated. Some people have it suspended. But on the other side of incarceration, people have to re-enroll or unsuspend their Medicaid status. They have to get back into their pharmacy benefit management program. They have to be able to meet with their provider. And that is, again, an incredibly heavy lift that might start helping us all see here why we're seeing 12 times higher all-cause mortality, or 120 times more likely of an overdose death on the other side. And the reason we did this was to try and stop cost shifting to the federal government. We didn't want to recreate the Willowbrooks. We didn't want to have places where people would be locked away, where they wouldn't have access to, where they would not be, where we'd have federal dollars pouring in with no oversight and really recreating asylums. So there was a reason for this in 1965, but as we're moving into a post-ACA world where we're trying to improve outcomes and improve care and access to care and coverage for people, the inmate exclusion is something that really gets in the way of trying to meet the aims of our healthcare system. It also limits the providers who can offer services within the facility. The Medicaid providers in the community are going to have to figure out another way to finance care if they're trying to offer it inside, and that is also a really incredible challenge. So what's been happening on the front with this inmate exclusion? The next slide will talk about this. I think talks about three really important changes that are coming down the pike and are really fascinating and are fundamentally going to change the way that health and justice systems operate across the country. Those three things are, first of all, state-driven Medicaid 1115 waivers. The second is a statutory change that go into effect January 1, 2025. And then third are new opportunities for federally qualified health centers to improve reentry coordination. And that is something that was released from the Health Resources Services Administration and is right now in policy, in draft policy form. But the final policy is going to be coming soon. And there have been some really interesting comments that have come through on that. And I'll touch on that at the end. So what is this Medicaid 1115 waiver? The next slide talks a little bit about that. So, just to do a bit of level setting, Medicaid is a state-federal partnership. Each state has their own Medicaid plan that fits inside of the broad federal outline of how a Medicaid program is supposed to be put together. But at the same time, the federal government allows for states to ask to waive certain components of the Medicaid program in order to better meet the needs and goals of the state. And so the 1115 waivers are a really great opportunity for states to try and do some demonstrations to improve care for people, and then to try and actually bake that into their long-term Medicaid plan. So I've been very grateful to be a part of trying to make sure that try and allow for 1115 waivers to be available for this inmate of a public, this inmate exclusion, inmate of a public institution exclusion that has made it so that people can't maintain their Medicaid benefits both inside and outside of incarceration. And so in April 17th of 2023, CMS, the federal agency that governs the Medicaid program, released a Dear State Medicaid Director letter. You can read the title there. The titles are so long in all of these federal documents that are coming out. And this waiver, this guidance, invited states to ask the federal government to waive this inmate exclusion under certain conditions. And really, the waiver is very broad about what a state could ask for. They could ask for basically the entire set of state benefits if they wanted to, but every Medicaid 1115 waiver had to offer at least medication-assisted therapy, 30 days of case management, 30 days of bridge medication, and case management. So states could waive this. They can't waive the inmate exclusion all across the board, but they can waive it for the last 90 days that someone is incarcerated. You remember I said earlier that people who are incarcerated in jails, for the most part, are there on average less than 30 days. So when we're talking about an inmate exclusion waiver for 90 days, we're really going to get the vast population of people who are incarcerated in a jail. In prisons, it'll be that last 90 days. But this is a really fundamental change to the way that healthcare could be delivered inside of the jails, and who could be the one financing those operations inside the jail, and also new transparency, new opportunities to collect data and really enhance the benefits inside of the jail. I should note that there's opportunities inside of the Appropriations Act that was just passed this last year to improve exploring the opportunities for this, and to also try and do some new things around making sure that we're doing suspension versus termination, which in my understanding Ohio is already doing. But really to start trying to plan for this. There's $110 million for every state in the country to try and do this and apply for these types of grants. So this is not an unfunded mandate, which is great. On the next slide, one of the major important features of this isn't just waiving the inmate exclusion for the last 90 days someone's incarcerated, but really it's an opportunity to improve health information technologies, to do new Medicaid expenditures, to improve business and operational practices, to improve hiring and training, to improve outreach, education, stakeholder convening, to try and really work on collaborations and fundamentally change the way that health and justice systems operate on a local and a state level. That's the investment side. The fascinating thing to me is this reinvestment opportunity that comes from this. Inside the guidance, it says that every offset state and local dollar must be then used to must be reinvested back in the state or local community to improve community-based physical and behavioral health services, HIT, data sharing, community-based provider capacity. And this, for me, is such a huge and important opportunity for those of us who have been showing up for people who are incarcerated all the time, to start talking about how these dollars could be better spent to help divert people from justice systems, to improve the care that's already offered inside of these justice systems, improve transparency, really have some fundamental changes by reinvesting these dollars that are offset by federal dollars. The next slide, we're going to talk about the statutory changes that are coming. So the Medicaid 1115 waiver, that's a state option. There's a lot of heavy lifts that are going to be associated with that I'm sure Patrick is going to share with us on the challenges of that. I've had the joy of being a part of several states who have already had their waivers approved for this and seeing their implementation. This is not easy. Like I said, 1965, these two healthcare systems, community and justice systems, diverged from one another, and now we're trying to bring them back together. That doesn't happen just from wishing and that it would happen. But unfortunately, or fortunately, at the same time, we kind of have this blunt instrument too that is happening, which was that in the Consolidated Appropriations Act of 2023, Section 5121 fundamentally changed the inmate exclusion policy for Medicaid eligible juveniles. And what that statute said, 5121, is it requires Ohio to put together a plan to offer screening and the diagnosis benefits for sentenced juveniles 30 days before release from a carceral facility. There are some provisos, and then it also requires 30 days of enhanced case management both before and after release. This is what we're going to be coming up against January 1 of 2025. We're all waiting with bated breath from the federal government to offer guidance on how this is supposed to look, but we haven't received that yet. Section 5122 also allows states to maintain the Medicaid benefits for unsentenced juveniles the entire time that they're pending disposition. So this might be triggering immediately in your mind, oh, this is just juvenile justice facilities. This is one of the challenges of working in these cross-silo situations, which is that sentenced juveniles is a Medicaid definition at this point. So it would follow the Medicaid definition of juveniles, which if you're an aged out foster youth could go all the way up to the age of 24. We have aged out foster youth up to the age of 24 inside of our state prisons and our jails too. So this doesn't just impact juvenile justice facilities. This is juvenile justice, jails, and prisons. And it's going to be really interesting how this unfolds. The next slide talks about that last major change, which is going to really, I think, fundamentally change who the providers could be inside of jails at the same time. So this draft policy information notice just came out. Comment period just closed 2 weeks ago on this. And what this would do would allow for federally qualified health centers and lookalikes to offer services to facilitate care transitions for people in the last 90 days. Basically, this is like, how do we allow for FQHCs to maximize these new waiver opportunities? Well, we had to pull in HRSA, the agency that oversees how federally qualified health centers are supposed to operate, in order to try and make sure that we could align the FQHC regulations with the opportunity that's inside of the Medicaid system. So what this would do would be allow for FQHCs to start offering, to change their scope, to offer services for people who are leaving incarceration. So it only is available for sentenced people, at least in the draft policy information notice. I know a lot of comments said this needs to also cover people who are unsentenced, because people move in and out of our jails all the time without ever being sentenced. So what this would do, allow for an FQHC to change their scope, to offer reentry services up to 90 days before release, but would also allow them to receive the PPS rate, the prospective payments rate for these services, which is really important for FQHCs, and also Federal Tort Claims Act protection for these FQHCs who are offering these services too. The implications of this are improved services, improved coordination, because it'd be the same provider on both sides of the walls, improved reimbursement, because the PPS rate is pretty great for FQHCs, to be frank, but also improved access to staffing programs like the National Health Service Corps as well. There's also opportunity too that came out of HRSA to fund these services for up to 2 years through a new grant. So I think that's the end of my presentation here. This is sort of what's happening on the federal level. And with that, I'm going to have Patrick bring us down to reality, I think is the next thing that's going to happen on this.
Hey, thanks so much, Dan. This is really intriguing to listen to on the federal level, and we're excited to hear more from Patrick, who is our Deputy Director in Ohio Department of Medicaid, just to gain a little bit more footing as to what's going on at the local level.
Thank you very much. I believe we've got a handful of slides. There we are. Great. So some of the material that I was going to cover has already been covered and done very well. Thank you. Why don't we click to the second slide? There we are. So we are conducting a series of stakeholder engagement sessions. We know that supporting incarcerated individuals as they re-enter the community is a critical issue. We've heard from many stakeholders interested in discussing this waiver opportunity. And so the governor has asked us to seek input from stakeholders. We are in fact-finding mode, trying to learn about the landscape of our carceral settings, both at local level and state level. Next slide. And next slide. So as Dan has indicated, there was a CMS guidance, state Medicaid director letter, announcing that states had an opportunity to pursue the 1115 waiver. 4 states have been approved, and there are 19 that are pending with CMS for review. Next slide. So there's some goals that are required as part of this kind of a demonstration: increased coverage, continuity of coverage, improve access to services, both prior to release, and improve transition to continuity of care into the community. The goal of improved coordination and communication between correctional systems, Medicaid systems, managed care plans, and community-based organizations. Increased additional investments in healthcare and related services to maximize successful reentry, improving connections between carceral settings and community services, including addressing health-related social needs, which is kind of a new thing in the context of Medicaid programs. Goal of reducing all-cause deaths in the near term post-release and reducing the number of ED visits and inpatient hospitalizations. Next slide. So there's a very wide variety of options states have when they're selecting the structure for an 1115. The sort of touch points or areas that states have to make sort of core decisions on are what facilities are going to be covered, who is going to be, what individuals are going to be covered. The minimum covered services are 3, but do you have a broader menu of services that you want? Is it the full Medicaid menu, or is it just a subset of available Medicaid services? Who are going to be the eligible providers, in reach or embedded? And what is the time period for covering the release services? Is it the 30 days pre-release? Is it 90 days? And so these are all critical decisions that states need to make in figuring out how to structure their 1115s. The time period for covering pre-release services is a tough one. It sounds simple, 30 days pre-release. However, most people don't know their release date. And so you don't know what that 30-day period is. And it becomes more of an issue of, are you going to look retrospective, have delivered services in the system, and then pinpoint the date that they were released and then count back for the purposes of reimbursement. But that kind of a structure can be complicated when you're dealing with systems that are entirely unconnected to EHRs and claims payment systems and external healthcare delivery systems. This becomes a very complicated thing to build, especially when you're looking at juvenile justice detention centers, county jails, community CBCFs, and so all of these systems are managed and maintained by different governmental units. And so you've got different organizations that have to be brought in to collaborate with to figure out what are their capabilities, what are their gaps, how do you fill those gaps? And it's a complicated thing. Next slide. So this is sort of a listing of the types of services that have been the top 3 are the mandatory: case management, MAT and counseling, 30-day supply of medication. And then states can add additional ones. So the optional services that have already been approved in one or more of the approved waivers for the other states are behavioral health consultation, medication administration, community health worker services, lab and radiology, durable medical equipment upon release, limited clinical consultation, and actually one proposal, which is still pending, includes housing-related case management or tenancy supports. That's a really important issue for individuals leaving carceral settings. If you don't have housing, you're going to be a very unstable situation. Next slide. So states are going to be required to reinvest the total amount of federal funds received through the demonstration for any existing carceral healthcare services that are currently funded with state dollars. So in that context, it's really not a savings, but rather an opportunity to expand. And so reinvestment isn't required for new services that are not presently being delivered, but if existing services are being provided and they're being replaced with Medicaid service funding, the state's going to have to show reinvestment that supports reentry. Next slide. So for 1115s, states are required to identify a hypothesis as to what is going to be the positive result if I waive this provision and design this structure delivery model. My hypothesis is that if I waive X, then I will achieve outcome Y. CMS requires reporting, tracking, and monitoring, the progress along that spectrum from X to Y. And in order to do that, states are required to establish milestones as part of their 1115. It's required for most any 1115 waiver. So in this case, the milestones that states are required to track to and attempt to achieve on this continuum are maintaining Medicaid eligibility, covering minimum services, continuity of care and case management, connection to post-release services, and cross-system collaboration with data sharing. Now, they sound pretty basic, but they're really pretty complicated because those connections and that continuity doesn't exist today, which is the problem that we're trying to solve. The hypothesis is if we waive the inmate exclusion, we will achieve better health outcomes through continuity of care. And the continuum isn't just delivery of services in the carceral setting. It's the continuation of the services outside the carceral setting that were started in the carceral setting. It's that unbroken continuum that's going to, in theory, under the hypothesis, produce the better result. Implementation plans are similar to other 1115s, how the facilities are going to be enrolled or whether they will be a Medicaid provider. Are you going to have embedded providers? How services are going to be provided, telehealth, how medications are going to be provided. You have to consider all aspects of bringing Medicaid into the correctional facilities. There is potential time-limited funding support for developing these programs, IT, staff, outreach, education, stakeholder convening. There may be opportunities for a 90-10 match on system upgrades. That's where the federal government contributes 90% of the cost of developing a new system. Next slide. So there's going to be some expectations from the outset for carceral settings to be able to participate in this kind of a program. They're going to have to be able to provide healthcare either directly or through another structure. There's going to have to be the ability to enter claims into a system. We aren't going to be able to do paper. Can't do paper claims. There's got to be EHRs. You have to have the ability to screen and pre-release eligibility, notify of eligibility, and release information to the state systems. This is going to have to be an actual nexus to the state systems. Either in the case of Ohio, it would have to be with our fiscal intermediary or our Medicaid managed care plans. You're going to have an EHR, either internal to the carceral setting or an external entity. The HR is needed to generate the claim. Next slide. And that's all I've got.
Thank you so much, Patrick, for establishing that. We've also got here today, we're joined by Isha Parnell. She joined MetroHealth in 2015 as a clinical nurse in correctional medicine. Since that time, she's held positions as a nurse management and associate director of nursing. She became director of nursing in 2021 and recently was promoted to the executive director of operations in 2024. She works closely with correctional medicine and jail leadership teams to ensure high quality, equitable patient care. In addition, we also are joined by Laurel Diaz. Ms. Diaz serves as Cuyahoga County's Justice and Health Equity Officer. In this role, she spearheads initiatives aimed at addressing disparities in access to justice and healthcare services. So we've got a couple questions that we're going to start with from the chat. One of the questions first is, if a person is in jail pre-trial, how do we know what the last 90 days of their incarceration will be?
I can speak to that. That's definitely a challenge, and Patrick alluded to that a little bit. The idea that we would have a solid date where we know how to back into that is really challenging. There are all sorts of folks that are incarcerated in our community. There are people serving sentences, which we absolutely know their release date. There are people going, awaiting prison or awaiting trial. But the vast majority of people are in and out of the facility within 30 days. So as we think about the framework of how this would work, we really have to do it at a kind of global level and look at the entire population. So Medicaid enrollment happening, while people are incarcerated in those first few days, making sure that they're connected to care really has to be on front loaded and very heavy from the moment that they kind of enter the facility or interact with the system.
Thank you, Laurel. So I'm wondering, Aisha, if you could tell us a little bit more about, just working day to day, how would this type of funding and these types of methods improve just the day-to-day work here with justice involved individuals?
Sure. If you don't mind, I'd like to share just one slide with you that kind of provides an
Sure.
overview of the services that we provide. One second.
While you're getting that together, how about we shift to a secondary question as well? The funding that we have available for these 1115 waivers, could that be used for some type of reentry housing or a health pilot?
I think that housing is a particularly important piece of the system. There are so many folks that come in that are unhoused in our facility or leave and don't have stable housing to go to. It creates challenges, of course, just generally, meeting basic needs, but even being able to assign them to like a community-based monitoring program. If somebody is released to a shelter, it's very challenging to have that ability to monitor them. The patient navigator that currently works on the MetroHealth team identified that 40% of folks that have a substance use or mental health issue do also have unstable housing. So that, from our perspective, from the kind of global social determinants of health perspective, housing has to be a part of it. Reentry services, absolutely. I think that the level of case management that could be done in the facility is much larger than what the current jail contractor, the county, has the ability to provide. So having additional streams of funding to support case managers at a larger level will be essential.
Thank you. Ms. Parnell, are you able to share that slide with us?
Are you able to see it? No, okay, I'll just go over it with you. I'm sorry
Sure,
about
thank
that.
you. Thank you so much.
Our facility houses on average about 1,700 patients on a daily basis, and within a 24-hour period, 60 to 70 patients are brought in through the facility. So at that time, we're responsible for ensuring that a comprehensive intake assessment is completed, that we identify any mental health, substance use, chronic care needs, and make sure that those referrals are placed and that care is provided. So having access to Medicaid services will just really help us to expand the care that we're currently providing within the facility. In addition to that, as Laurel indicated, the addition of patient navigators and care liaisons helping us to reintegrate patients in the community, helping us to ensure that the care that we provide here is continued so that we can ultimately reduce recidivism and decrease the risk for patient harm.
Thanks so much. So we do want to go back, if we can, to just describe a little bit more about the housing pilot or some type of study and utilizing those funds. If we can go back, I believe there was a slide. Dan, if you could go back to discuss a little bit more about that, or Patrick.
So yeah, let me share some of the experiences of what some of these other waivers that are happening right now. There, there's quite a few 1115 waivers out there. They're not all just justice involved waivers and reentry waivers. And states have been experimenting. Hawaii was one of the first. California and their new CalAIM waiver brought in these services in order to try and support people as they're moving into housing. How do we try and keep them in the housing that they're there? How do we help them be able to have a peer support as they're trying to show up for HUD meetings and all these different things, right? So there are ways in which different states are trying to experiment with how do we support people as they're trying to secure housing. And so I want to tease out one other thing is that we don't want Medicaid to pay for things that Medicaid doesn't need to pay for. We want to use Medicaid and really bolster some of these other opportunities that people have to secure housing through HUD programs, through just different opportunities to expand housing for people and access to housing. We don't want Medicaid to be the panacea for absolutely everything. So what I think could happen with a waiver is that you could imagine that being like California or Hawaii, there are opportunities to try and support people through case management or peer support to help them be able to figure out and wend their way through the very complicated programs to try and get into some of these housing opportunities. And then once they're released, they could be placed into a certain reentry housing that might work for them, but that reentry housing would be paid for through a variety of different methods that are not necessarily Medicaid. But we could then weave in the different behavioral health supports that people might need or have through whatever Medicaid is already paid for and paying for people when they're in the community. So these waivers are for, just think of it, it's for the time when people are incarcerated. So it's just those last 90 days. But then those reinvestment dollars could be absolutely, really creatively deployed in ways to try and support and expand whatever holes that there might be as we're braiding together HUD funding, local Adams dollars, all of these different opportunities that exist out there, but there just might not be necessarily the glue to hold them together. And that's where I think there's a really powerful opportunity with the reinvestment dollars.
Right. And so, this, of course, is obviously one strategy to enrich the lives of justice involved individuals, right? And we've talked about the complexity overall throughout this conversation, how this is a really complex process. So folks are wondering too, as this is a demonstration, should we be utilizing the demonstration in larger counties first? Have we considered that? Larger counties that may have the more complex electronic health records, for instance?
So that's one of the reasons that we're doing these fact-finding stakeholder sessions is we need a pretty good understanding of the landscape out there. What are the readiness levels of, and it's not just a county issue, it's a carceral setting issue. So you're going to have multiple carceral settings in a county. Some may be quite ready. Other carceral settings in that same county may not be at all ready. So it's not a county issue, it's a carceral setting issue. It's also a population question. Who do you want to cover? Who is your greatest need population? And in terms of the services, so there's a lot of factors that go into sort of decision making. I'm not the decision maker in this. That is a group of individuals with a much higher pay grade, but I'm sort of heading up the fact finding.
Can I just take a moment and say how proud I am that Ohio is doing it in this way? Since this is Ohio podcast or a Zoom conversation, I'm more than happy to cast aspersions on other states. When working with folks in California as they were putting their waiver together, I said, how are you reaching out to justice system partners? How are you reaching out to counties to understand what's going on there? And the response I got from that, speaking of pay grades, incredibly overpaid agents, companies that write the waivers for states when they're doing it, they said, we'll write it and the sheriffs will have to do it. And that is not the way to create a transformative program. It's not the way to really make sure that you're actually listening to what's going on inside of these facilities and actually creating responses that are going to meet the needs there. So I think that, California wanted to be the first ones over the line, and try and be like, oh, we're the trailblazers and all of that. I think it's a lot better to make sure that we're really thinking about the people that we're serving and the communities and what we're trying to do here. And so I just think that I want to heap accolades on the state for going about it in this way.
So this has been, I'm sorry.
Randy, I'd just like to add something to Dan and Patrick's comments. I think, here in Cuyahoga County, we are well poised to do something like this, but we recognize that other folks in other counties and rural areas and the justice system overall there will be challenges. But I just want to point out that our county, not only do we have a really amazing correctional medicine program that has a connection through the EPIC system to almost all of our community partners in our community. But we are, embarking on a new jail campus strategy that's backed by the executive that really looks at all the points that Dan was talking about around diverting people away from, people that have these diagnoses that don't need to be in the facility. How do we work to ensure that that's happening? how do we increase the level of care inside of the facility, both with case management, but, higher levels of care around behavioral health management and SUD. And then finally, the reentry strategy as well. So there is a broader kind of initiative and a buy-in around how do we really transform the system in our community. And this Medicaid waiver would really layer over that in a really beautiful way. And so just to echo again what my colleagues are saying, that this opportunity is life-changing for people, and we are fully supportive of pursuing it and supporting our partners as well.
Sure. Thank you. And so as this would be life-changing, can you tell me, especially Ms. Burnell, can you speak a little bit to more of how the change would happen, or Ms. Diaz, for, like the delivery of actual care to these individuals?
Sure. As I mentioned earlier, it would just allow us the opportunity to continue this care, to allow our patients to have access to the same resources in the community, for there to not be a gap or a lapse of time where they're not receiving services, because in that gap of time, we know that the likelihood is much higher that they'll return. So we're looking at the reduction of overall recidivism. We're looking at the improvement of healthcare within the community. We're looking at access to preventative healthcare, so that if patients do arrive here, they're not in poor clinical mental health or, substance use disorder conditions. So that transition just would allow us an awesome opportunity to touch the lives of those who unfortunately don't have access to the care that they need prior to arriving or after they leave here.
Yeah, just to echo what Aisha's saying, is she and I have worked closely on, hand to hand, just seeing some of the most severe and sickest, most ill folks in our community walking through those jail doors. To have case management available to literally, warm handoff and walk people through the process as they leave. I think what we found in our county, that many of the folks in our system had an interaction with managed care, but there were many that were uninsured and unconnected. And so we have done a really good job of putting bumpers around when they walk into the jail and providing those services. And there are support services to lead folks back through, into the community through the jail liaison program and the Office of Opioid Safety. But there's so much more work to be done. We're releasing 80 to 100 people a day. And the volume is such that you can't keep up with it with the existing model of care. So I think that, having the level of care that could be possible with this type of transformation is what I'm talking about. I think what we're all talking about in terms of life-changing.
Thank you.
I'm sorry. I just would like to add, we also need to make sure that we're working to eliminate the stigma surrounding correctional medicine, because there are so many people who believe that patients who are in custody don't deserve care. And Dan, as you mentioned, these are people's loved ones, their uncles, brothers, fathers, mothers. So we want to instill that same sense of hope in the community. Our patients deserve care just as if they were in a hospital setting or any other ambulatory facility.
Can I share a personal story on exactly that issue? So, family member, right? Here we are, Northeastern Ohio. I have my cousin's husband has been addicted to opiates since he was 13 years old. Found pills in his parents' vanity, started using them. My cousin, love her. She has been with him through all of this and support him through it. He's had really challenging times of getting his life together. When Medicaid expanded for the first time ever in his life, he had the access to a substance use program that helped him. It was a polysubstance abuse program where he could be able to receive treatment for benzodiazepine and also his opioid use disorder. He had a criminal record, of course, by the time he was, 18 years old. He was arrested for having an unregistered gun, taken to a jail. He was incarcerated. He was in that polysubstance use program in the community, Medicaid supported. The moment he was booked into jail, he couldn't go to that program anymore. Medicaid can't reach inside of those walls. He was dropped from the program. He was only in there for a week and a half. When he was released back into the community, he tried to reach out to that provider and said, "I'm so sorry that I missed the last 2 weeks. I really need to come back. I need to be a part of this again." They gave him a urinalysis test. He was no longer positive for benzodiazepines because he had been off of them. So he couldn't participate. He couldn't be re-enrolled in that polysubstance use program. That's something that was caused by this discontinuity of care inside of this. And on the other side of it, I mean, he really spiraled too. Major challenges with being able to hold down a job, being able to support his family. A lot of that fell to my cousin and even her kids as they were aging and, became adults, to become the breadwinners, because he's really had challenges coming back from that major hurdle. And he's had so many other hurdles in his life. So, these are the sorts of things that happen when we just just have it be that a person who's receiving care on one side, suddenly it's gone. And sorry that there isn't something for you on the other side. And I just wanted to share that really personal story.
Thank you for sharing that with us, Dan. That continuity of care is so important and really vital just overall. When we know that there are already programs in Medicaid working with prisons, but of course, maintaining that continuity of care is essential moving forward. So having expanded programs like this complex, even though it may take a while, like this complex demonstration would be necessary in improving that continuity of care for sure. Speaking of complexity and timelines, traditionally, how long would something like this demonstration take to implement?
Patrick,
yeah.
good.
Well, I was on a national call with a bunch of folks, and some folks from California said it took them 3 years to develop theirs. This kind of program is so complicated and has so many touch points in terms of an absence of an existing framework. This could take years. It could take years.
But even
11, yeah, I was going to say
right.
typical 1115 takes at least a year,
Mhm.
a minimum, and this is no typical 1115.
Yeah.
Right.
So how it's looking in other states is, I mean, that's exactly it is taking a long time for implementation. California was, working on this for a while. They received their approval first, and they still haven't actually gone live with any billing while people are incarcerated. And that's, it's because, like I said, this is 60 years of divergent evolution of these systems that we're trying to bring back together. It's not simple. Also, the waivers require, implementation plans. So you've got to go to facilities. You have to figure out, first of all, how are we going to judge whether facilities are ready for this or not? And then we got to get CMS to approve of that. And then what are we going to do for the reinvestment on the other side? It's absolutely a huge change. But this is at the same time is like, this is something that is so deeply transformative. And
Right.
I'm not surprised at all that the health disparities in our community systems and the disparities in our justice systems really mirror one another. And I think that this health component of it is one of the major reasons for that. And so if we're serious about tackling people when they are at their most critically at need and really trying to figure out how do we build a system that improves access to coverage and ultimately drives down costs and allows people in the community to say how we want this structured. That's what I love about this reinvestment component of it. It is people saying, actually, we need to do some really housing, focus on housing for this reinvestment dollars. Those are really powerful things and really brings in engagement of people who have often felt powerless inside of these systems. And I think that that's such a really important opportunity too for what we could build.
Aisha or Laurel, we've got a couple minutes left, but I'd really like to get to this last question. Thank you, Dan. Just about how would you, speaking of reinvestments, how would you use those reinvestment dollars in your work?
I can take it first. I think that like has been said many times, I think the idea and the concept around case managers, around peer navigators, around really, lower license level folks that have lived experience working hand in hand with people that are incarcerated is a transformational type of programming that we just, I think there's opportunities in the private funding community to pursue grants and things like that. But again, just going back to the volume of folks that need help, when you think about, 15 to 1,600 people that are in the facility today and the amount of support that they need when they are really the most need and in the most, kind of tragic situations of their lives, you can't comprehend the volume, the volume of support that they need
Right.
and the cost around that. So I would really see an investment very heavily on that side. And it's not about investing in one particular organization, but really like kind of spreading that, there's more than enough need to go around, and like helping our community partners get in there to, to help make those connections happen. I would love to see too, the housing piece, and whether that's just, doing some, while folks are in there, making sure that they're, integrated into the rapid rehousing system in our community. And then, making sure that when they leave, they actually have a solid place to go, would be really great as well. But really, focusing on these social determinants of health that really cause folks to get into, this system and this cycle.
Right. Thank you so much. This has been an amazing conversation. Thank you to each of our panelists, and thank you to everyone who's joined us today. We've got some information in the chat, and we'll be sending out a copy of this recording as well as a copy of the materials here today. So thank you so much, and we hope that you have a great rest of your Friday.